Good morning, everyone. Today we welcome back Dr. Dan Hallam, a board-certified general surgeon with Springfield Clinic. He's also on the active medical staff here at Passavant Hospital. Dr. Hallam and I will be discussing colorectal cancer and screening. I am Dr. Peter Russotto, your host and moderator. The month of March was National Colorectal Awareness Month, so you see, this topic is very recent in public health discussions. Many of you, the listeners, might have recently had a talk with your family physician about a screening colonoscopy, or maybe already are scheduled for one. Well, Dr. Hallam is here to inform us as to why we need screening colonoscopies. I'm also sure he will encourage you to discuss this with your family physician. Well, concerning colorectal cancer, what are the statistics here in the United States, Dr. Hallam?
Good morning. There's approximately 150,000 new cases of large bowel or colon cancer diagnosed each year. Out of this, about 50,000 Americans die of colorectal cancer a year. Approximately 9% of all cancer deaths are related to colorectal cancer.
Is there really a difference between men and women?
Yes, there's risk factors, and there is difference in gender as well as age. What we know is there's about a 5% lifetime risk of colorectal cancer. 90% of these occur after the age of 50. At the age of 80, about 1 in 10 males are affected versus 1 in 15 females.
Concerning the signs and symptoms of colorectal cancer, can you give our listeners a little general description of those?
About 44% of folks will have complaints of abdominal pain, as well as change in bowel habits. You can have blood in the stool or dark, tarry stools. Weakness is also associated with this, as well as anemia and weight loss. Now, these are signs of symptomatic cancer, and that's one of the reasons that we want to talk more about screening. The purpose of screening obviously is to help us save lives associated with colorectal cancer, but screening is also associated with finding cancers at a lower stage. Of course, survival and treatment is significantly improved the earlier that the cancer is caught.
You mentioned some of the signs and symptoms. I wasn't quite sure. Did you also mention just even a change in bowel habits?
Change. Almost 40% of folks that have symptomatic cancer will have complaints of change in bowel function.
And while you already mentioned screening, can you discuss some of the screening guidelines and some of the screening plans that are available here in the United States?
Yes. With folks with an average risk of colon cancer, and I'll talk more about that in a minute, the recommendation is to start screening at the age of 50. And then every 10 years thereafter, again with an average risk. And what we're talking about as an average risk is no family history of colon cancer and no history of polyps or symptoms. Patients with family history of colon cancer and a primary relative, so a brother, sister, mother, father, are considered higher risk. We usually recommend screening earlier in that population, as well as if there's a history of colon polyps, significant history of colon polyps. There's also some rare genetic risk factors for colon cancer, which makes you at higher risk for polyps as well as higher risk for cancer. And we recommend screening at an earlier age with that as well. As far as the screening tools, again, starting at the age of 50, we would recommend a colonoscopy 10 years thereafter. Now, there's other screening tools that can be used. They all have pluses and minuses associated with this. One would be doing hemoccult testing of the stool, and we recommend that on a yearly basis if you use that for your screening mechanism, and that's where each year the stool is tested for microscopic blood. The negative to that is usually when you start having blood or microscopic blood in the stool, there's a chance that there's already a cancer developing. With colonoscopy, we're looking to find cancers, but what's more common is polyps. Polyps are where you have an overgrowth of tissue on the inside of the colon. Most polyps are considered precancerous. They're not cancer, but they have the potential to become a cancer. And the reason we think that is because most, if not all, colon cancers arise from a polyp. And so if we can find the polyp and remove the polyp, then theoretically the risk of cancer has decreased and you've prevented that. Also, we've identified a patient that has polyps, and that puts that patient in a higher risk category for developing colorectal cancer. Other screening mechanisms, barium enema. This is a procedure performed in radiology where a patient receives an enema of barium and then usually has air also injected into the colon, and then a series of x-rays are taken. If this mechanism is used, we recommend that every 5 years after the age of 50. The negative side of that, if there is something seen on the barium enema, then most of the time we recommend a colonoscopy. There's also flexible sigmoidoscopy, which is similar to colonoscopy. However, the colonoscope is not advanced throughout the entire colon. It mainly is limited to the left side of the colon. If we use flexible sigmoidoscopy, we usually recommend this every 5 years as well. There's also newer modalities. One is called CT colonoscopy or colonography. This is where you have a CT scan with contrast, and again, air is injected into the colon for better view of the colon. With this, again, we would recommend that every 5 years, and if there's anything seen on that, then we would recommend a colonoscopy.
The CT colonoscopy, is that another way? Sometimes you see in magazines what they call the virtual colonoscopy?
Yeah, usually when we refer to virtual colonoscopy, it depends. Sometimes it does refer to the CT as well, but there's also a pill endoscopy where you actually swallow a small camera that's used to basically photograph the GI tract. It doesn't work as well for the colon. It works better for the small bowel. And so we usually reserve that for cases where, for example, there is some bleeding from the GI tract. The patient's had a colonoscopy, had an upper endoscopy in which we've looked at the stomach and the first portion of the small bowel, but haven't located any source of bleeding. Then we would recommend more of a capsule endoscopy.
So basically, though, these screening tests are also tailored towards the person's age, the pathology of which you find, correct, as far as when you would have to repeat them for further surveillance?
That's correct. For example, on a colonoscopy, if we find multiple polyps and after the pathologist looks at the polyp and it's deemed that it's higher risk type of polyp for developing colorectal cancer, we might recommend every 3 to 5 year screening based upon that.
Would you say, though, that basically probably the colonoscopy is the gold standard?
Yes, it's the right now it's the most sensitive test that we have. Yes.
Okay. You touched a little bit about major risk factors for colorectal cancer. Mm-hmm. I'm sure diet, smoking. Can you elaborate on that a little bit?
All of those are involved. Age is the number one risk factor for colorectal cancer. As I mentioned earlier, 90% of colon cancers occur at the age or greater than 50 years of age. That's the reason we've kind of selected the age 50 to start the screening. It's rare to have a cancer younger than that. Obviously, we see that. With advanced age, the increase of colorectal cancer increases significantly. Diet has been linked with colorectal cancer. High-fat, low-fiber diets, folks in that category have a higher risk of colon cancer, versus a high-fiber diet tends to lower the risk of colon cancer. Obesity is linked with a higher incidence of colorectal cancer, as well as there's genetic predispositions to colorectal cancer. There's genetic mutations that in which individuals can have many polyps, sometimes up to 1,000 polyps, and this condition is linked to a higher risk of colon cancer. And there's other syndromes such as Lynch syndrome, which has a higher incidence of colorectal cancer. Conditions such as inflammatory bowel disease, Crohn's disease, ulcerative colitis also has a higher risk of colorectal cancer as well.
Is there any studies that show an active lifestyle decreases somebody who exercises as
Correct.
opposed to sedentary lifestyle?
Correct. An increase in physical activity is linked with a decreased risk of colorectal cancer versus a less physical activity has a higher risk of colorectal cancer. Smoking, which you had mentioned earlier, is also linked with a higher risk of colorectal cancer.
To put some of our listeners' minds at ease, we briefly discussed blood in the stool, sign possibly of colon cancer, but there are many other things that the blood could be from, even such things as like hemorrhoids or anything.
Correct.
And some of the inflammatory bowel disease.
Right. And that's true. Most of the patients that we see in the office that we're evaluating for blood in the stool, most of these do not have cancer. It is related to hemorrhoids, diverticulosis, which is where you have a pocket in the wall of the colon, as well as sometimes even an upper GI tract, such as ulcers and things such as that.
But that definitely warrants a patient to seek medical advice,
yes,
if they ever see it at all.
Yes, if you have change in bowel functions, you have blood in the stool, then I would urge you to talk with your primary care doctor. Yes.
Anything else you want to add about today's discussion, Dr. Hallam?
Well, as far as colonoscopies, a number of people obviously have high anxiety associated with colonoscopies. The procedure itself usually takes about a half hour. It requires a driver. This is done under sedation. The procedure itself is painless because of the sedation. The worst part of the whole thing is usually the day before, which requires a bowel prep in which patient is on usually a clear liquid diet, and then we prescribe a medication which essentially flushes the GI tract, and that process, when you get feedback afterwards, most people will say that was the worst part of the whole thing. As far as the actual procedure itself, the patient's very comfortable. They are not exposed in the sense that keep them covered throughout the procedure in the endoscopy suite. Most people, when it's over, they ask us when we're going to start, and that's how comfortable they are.
Even though it's a procedure, I want the listeners to realize, and I'm sure you can talk more to it than I can, it is a very low risk for complications.
It is. Anytime you have a procedure, obviously there's risk for complications. Major complications from colonoscopy is about 1 in 1,000, so it's about 0.1%. That's not zero, obviously. There are risks associated with this. There's risk with the sedation. So we have to screen our patients to make sure that they're healthy enough as far as from a cardiac and a pulmonary standpoint. But overall, it's a very safe procedure.
Definitely the benefits far outweigh the risks.
Far outweigh, yes.
Okay, well, I thank you very much for that interesting discussion, and I want the listeners to realize that there's the general surgeons here at Passavant are here to help you to discuss this should you need a colonoscopy, and I say thanks for listening and good health to all.